Revision of Ileostomy, simple, release of superficial scar. The physician revises an ileostomy through an incision around the stoma with release of scar tissue. The physician makes an incision around the ileostomy site. Next, the stoma is dissected free of the surrounding abdominal wall and constricting scar tissue is released. The stoma is proximate to the skin or the distal end of the stoma may be transected. Additional ileum may be pulled through the abdominal wall and approximated to the skin as a revised ileostomy. Revision of Ileostomy, complicated, reconstruction in depth. The physician revises an ileostomy by forming a new stoma site. The physician makes an abdominal incision. Next, the previous ileostomy is completely taken down. The distal ileum is brought through a new incision on the abdominal wall onto the skin as an ileostomy at a new site. The initial incision and former stoma site are closed. Revision of tracheostomy scar. The physician revises a tracheostomy scar. The physician incises the skin around the tracheostomy scar and removes the scarred tissues. The incision is sutured in layers, leaving a less noticeable scar. Continent ileostomy, cock procedure. The physician forms a reservoir of distal ileum, cock pouch, and brings it through the abdominal wall onto the skin as a continent ileostomy. The physician makes an abdominal incision. Next, the distal ileum is folded upon itself and approximated in such a way to form a pouch with a valve. The end of the pouch is brought through a separate incision on the abdominal wall onto the skin as a continent ileostomy. The initial incision is closed. Revision of colostomy, simple, release of superficial scar. The physician revises a colostomy through an incision around the stoma site with release of scar tissue. The physician makes an incision around the stoma site. Next, the stoma is dissected free of the surrounding abdominal wall and constricting scar tissue is released. The stoma is proximate to the skin or the distal stoma is transected and additional colon pulled through the abdominal wall and approximated to the skin as a revised colostomy. Revision of colostomy, complicated, reconstruction in depth. The physician revises a colostomy by forming a new stoma site. The physician makes an abdominal incision. Next, the previous colostomy is completely taken down. The distal end of colon is brought through a separate incision on the abdominal wall onto the skin at a new site as a revised colostomy. The initial incision and previous stoma site are closed. Revision of colostomy, with repair of paracolostomy hernia. The physician performs a colostomy revision and repairs a pericolostomy hernia. The physician makes an abdominal incision. Next, the previous colostomy site is taken down. The hernia at the former colostomy site is repaired. The end of colon is brought through a separate incision on the abdominal wall at a new site and onto the skin as a revised colostomy. The initial incision and previous stoma site are closed. Tracheostoma revision, simple, without flap rotation. Complex, with flap rotation. The physician revises a tracheal stoma. The physician incises the stoma area and resects redundant scar tissue or a poorly healing wound. The skin is reanastomosed and sewn to the stoma in sutured layers. Report 31613 for performance of a simple revision and 31614 if a complex procedure is performed with flap rotation. Revision of implanted intra-arterial infusion pump. The physician performs an upper abdominal incision and exposes the hepatic artery, locating the previously implanted infusion catheter. The physician may unkink the catheter or replace it over a wire. The physician secures the catheter with suture and closes the abdominal wound around the proximal end of the infusion catheter. The physician may use the catheter to administer chemotherapeutic medication. Revision, including removal of prosthetic vaginal graft, vaginal approach. The physician revises or removes a previously placed prosthetic vaginal graft via a vaginal approach. The patient is placed in the lithotomy position and a speculum is inserted. The physician visualizes the vagina. The apex of the vagina is accessed with deep retractors. Dissection is carried out to reach the affected graft material. Depending upon the type of complication, i.e., stricture or infection, the vaginal graft may be completely or partially excised to remove eroding mesh, or revisions may be made in the graft and surrounding tissue. The vaginal epithelial layers and pelvic fascia are rearranged or reproximate and closed. Vaginal packing is put in place. Revision, including removal of prosthetic vaginal graft, open abdominal approach. The physician revises or removes a previously placed prosthetic vaginal graft using an open abdominal approach in conjunction with a vaginal approach. A laparotomy incision is made and the physician dissects into the pelvis. The vagina is elevated with tools or with the physician's hand. The graft is located, the peritoneum is opened over it, and the graft is dissected free and removed. Depending upon the type of complication, i.e., stricture or infection, the vaginal graft may be completely or partially excised to remove eroding mesh, or revisions may be made in the graft and surrounding tissue. Endopelvic fascia is reproximate and the vaginal epithelial layers and pelvic fascia are rearranged or reproximate and closed. The abdominal incision is repaired in layers. Vaginal packing is put in place. Adjustment or revision of external fixation system requiring anesthesia, e.g., new pin, S, or wire, S, and / or new ring, S, or bar, S. The physician places the patient under anesthesia. Additional pins, wires, rings, or bars may be needed or existing ones moved. The physician drills a hole through the bone and inserts the pin or other fixation instrument, which is attached to external frame devices. Revision of gastroduodenal anastomosis, gastroduodenostomy, with reconstruction, without vagotomy. With vagotomy, the physician revises and constructs an anastomosis between the stomach and the duodenum. The physician exposes the stomach and small intestine via a midline upper abdominal incision through skin, muscles, and fascia. The connection between the stomach and duodenum, gastroduodenostomy, is severed and the duodenal stump is closed. An 8 cm to 10 cm segment of the jejunum is reversed and anastomosed to the distal end of the stomach. The excised duodenum and segment of jejunum are connected to the jejunum. The abdominal incision is closed. Report 43855 if a vagotomy is performed in conjunction with this procedure. Revision of gastrojejunal anastomosis, gastrojejunostomy, with reconstruction, with or without partial gastrectomy or intestine resection, without vagotomy. With vagotomy, the physician revises an anastomosis between the stomach and the jejunum. The physician exposes the stomach and small intestine via a midline upper abdominal incision through skin, muscles, and fascia. About 8 cm to 10 cm of the jejunum limb is divided, reversed, and connected to the distal end of the stomach. The short reversed segment is connected to the jejunum and the remnant of jejunum and duodenum are anastomosed to the long segment of jejunum. A partial gastrectomy or intestine resection may be performed. The abdominal incision is closed. Report 43865 if a vagotomy is performed in conjunction with this procedure. Implantation or replacement of gastric neurostimulator electrodes, antrum, open. Revision or removal of gastric neurostimulator electrodes, antrum, open. The physician performs placement of gastric neurostimulator electrodes in an open procedure. Through a laparotomy, the physician enters the abdominal cavity. The antrum of the stomach is identified and the physician secures 2 electrodes to the muscle of the pyloric antrum. The physician closes the laparotomy with layered sutures. Report 43881 if electrodes are placed or if existing electrodes are removed and replaced with new ones. Report 43882 for the revision or removal of the electrodes. Under general anesthesia, a midline incision is made, starting at the xiphoid P process and extending approximately 4 cm to 6 cm in length. The stomach is exposed using standard surgical technique. Acil area are taken. Revision or removal of intracranial neurostimulator electrodes. The physician removes or revises neurostimulator electrodes. The physician incises and retracts the scalp and drills a burr hole in the cranium to locate the electrode. The electrode is removed or revised. If necessary, the electrode is replaced. The dura is closed and the scalp is reproximate and sutured in layers. Revision or removal of cranial neurostimulator pulse generator or receiver. The physician removes or revises a pulse generator or receiver within the subcutaneous pocket. The physician incises the skin above the unit. After locating the generator or receiver, the physician removes it or makes any necessary revisions to it and closes the incision. Revision, open, arteriovenous fistula, without thrombectomy, autogenous or non-autogenous dialysis graft. With thrombectomy, autogenous or non-autogenous dialysis graft. The physician makes an incision at the site of an already existing artificial fistula between an artery and a vein. The fistula is dissected free. Vessel clamps are affixed above and below the fistula, which is incised. Revisions are made to the fistula at its juncture to the vein and/or artery and may require creating a new anastomosis with a graft obtained from a separate site or created with synthetic material. After the repair has been made, the fistula is sutured, the clamps removed, and the skin incision repaired with a layered closure. Report 36833 when the physician removes a blood clot at the fistula site in addition to revising the existing arteriovenous fistula. Revision or repair of operative wound of anterior segment, any type, early or late, major or minor procedure. The physician re-explores an eye wound that is the site of previous surgery to revise post-operative defects. The physician uses a number of techniques, based on the wound and previous surgery. Surgery may be major or minor. Revision of urinary cutaneous anastomosis, any type urostomy. With repair of facial defect and hernia. The physician revises any surgical opening, anastomosis, between the skin and ureter, bladder, or colon segment. The physician removes the sutures securing the anastomosis to the skin and revises the anastomosis. The physician may make a midline incision in the skin of the abdomen to access the urinary tract.